Can you maybe share a bit about patient inclusion criteria? One of the things that I think we get asked a lot is what type of patient should be enrolled, and then how do you actually drive volume? How do you get those patients enrolled into the program? Because it's one thing to say this is who we're taking, and it's another thing to then get volume. Can you talk a bit about how you've defined your inclusion criteria?
From an equity lens, there are a lot of misconceptions about home hospital as a care model for folks who are perhaps wealthier and live in large homes and perhaps of a certain race and ethnicity. And I can't share enough how inaccurate that is. In our UMass Memorial Home Health Program, we care for about 35 to 40% of our patients in our program have Medicaid, so health insurance for low-income populations. We will go into all variety of homes. We've cared for a gentleman who lived in a wig shop, single room occupancy homes, and to shared informal living arrangements. With the Current Health colleagues and platform, we're using your wireless technology so they don't have to have internet. We're feeding them, we're bringing them food. The tablets have languages on them, so we're speaking their language. Many of our patients don't speak English. Many of them are sort of underserved, social determinants challenged populations. And there's actually some data to suggest that when you care for those populations, they disproportionately benefit from home hospital versus non-Medicaid populations. And so I think that's just one piece about patient inclusion that I want to be very strongly oriented around. But I think there's also some very pragmatic things, which is what types of patients are you caring for and risk tolerance. And so, Candy, let you talk about the inclusion exclusion. And I think it'd be fun to also talk about sort of a holistic view of risk tolerance.
Thank you, Taki. In a nutshell, we try to take care of anyone who comes our way that has a home and electricity for us to take care of them in. As Taki mentioned, language is, not a barrier to us. And with our Current Health device, our patients don't even need an internet. We actually bring that into their home. So we just try to be as inclusive as we possibly can. That initial safety evaluation that we do is incredibly important, but we're finding on a regular basis that patients may appear really well put together, and they'll tell you they have food, and they'll tell you that they have a weatherproof home or room that they're living in. And when we get there, we actually find something very different. So those social determinants of health, and then those in-home visits to make sure we can shore up some of the issues that we find. For example, a CHF patient who's had frequent hospitalizations tells you that they have plenty of food, but when you get in the home, it's all takeout containers, which is not the healthiest diet for heart failure patients to be on. So we spend a tremendous amount of time doing education, whether it's dietary education, home safety education, medication reconciliation is incredibly important to us. You'd be quite surprised to find how many patients, can hand you a list of the medicines that they're on. But when you get in the home, half of those prescriptions may not be filled. There may be multiple doses of the same medications. We've had a patient who was just so confused, he just gave up taking any medicine at all, which of course, is how we met him when he presented to the emergency department. So we just spend an extraordinary amount of time making sure that we're shoring up our patients' environment, doing the best to add whatever services they need to keep them safe going forward, making sure that there is a PCP involved. And we like to think that when our patients go back to the PCP, we've painted a much more robust picture of what their real environment is, so that their primary care team can take much better care of them, because we've given them a whole picture of their living conditions, the kind of supports that they need, their family involvement. It's fascinating what you can learn in a home and bring together.
And at a very pragmatic level, to Candy's point, in addition to, we obviously need to make sure they have a home, running water and electricity, but we essentially bring everything else. what we've tried to do as a team is say to ourselves, what services does this patient you're looking at need, and can you meet their need and provide standard of care, and frankly, better than standard of care? And so we look through the orders and we say, can you execute all these orders that are in the inpatient setting? And if the answer is yes, and there's not an MRI pending or a CT pending that they need urgently, that's often a very appropriate candidate. And one of my jobs and Candy's jobs, and we talk about this all the time as a leadership team, is to find the right risk tolerance for a program. Because remember, we're caring for patients who have a lot of concerning safety events in brick and mortar facilities. They typically are older, they often have social determinant challenges, they're very high risk of falls, infections, DVTs, loss of function, transfer to skilled nursing facilities. And so you have to sort of as a team say to yourself, this patient is on oxygen and is pretty sick, but guess what? We can provide high acuity inpatient level care. And so what typically happens is that there's a first 10 to 20 patients of sort of courage building. And then once you get past that first 10 to 20 patients of courage building, the courage is there and you realize that the patients do amazing, and then you're kind of off to the races. And so that's the really vulnerable part, is the first month.
I think probably talking one of the best examples, we took just a delightful woman home, and her daughter tried to tell us she had some challenges at home, but it turns out she had a significant issue around hoarding. And so when our team first walked in, the ceiling was in disrepair. There was just literally stuff everywhere. And the first inclination, the nurse FaceTimed me and was, kind of showing me the home. And I was like, oh no, I don't know that we can do this. But, after you take a deep breath and step back, we huddled together via conference and decided, what risk we could take. They were able to clean a path to her, get her safely to her bathroom. She certainly had running water. We got her food in her home, and we took amazing care of her. And I think to Taki's point, that risk, you start out very conservatively because, to be honest with you, none of us have done this before. Taki has, but the nursing team hadn't. We are so much better at that now that it's really about, let's just get them home and take amazing care of them. So it's so true that your risk tolerance does go up. And, some days, when we realize the wig shop, did we make the right decision? But guess what? We took great care of that gentleman. And every day we just make it work.